Good morning, everyone, and welcome to this session as part of the Frontline Network's amazing annual conference. This session, which is about health inclusion and exclusion, we're going to be exploring some of the main challenges, but also some of the opportunities and examples of good practice when it comes to providing healthcare and healthcare access for some very socially excluded groups in our society. We've got some presentations about some research, we've got some fabulous presentations from services as well. So I really hope you all find it to be an interesting and informative session. Just to introduce everyone before we get started. So my name's Theo Jackson. I'm going to be chairing today's session. I work at Pathway, which is a homeless and inclusion health charity, as research and data lead. Before joining Pathway, I was working as a coordinator in a shelter for homeless migrants. And I also have a research background in mental health and cognitive science. We're being joined today by three amazing panelists who are all doing fantastic work down in Brighton. So just to introduce them, firstly, we have Hannah Bishop, who works as the lead nurse for Arch Homeless Healthcare in Brighton. She qualified as a nurse in 2003 in Manchester, where she developed an interest in health inequalities and then did postgrad studies in substance misuse, after which she moved into general practice nursing in 2010. We're also joined by Jules Grenville, who's the network's project manager at Justlife, where she supports with the coordination of the Brighton and Hove Frontline network. She is also a participation lead on Brighton and Hove Common Ambition, which is a lived experience-led systems and healthcare improvement project. And last but not least, we are joined by Sara Emerson, who has worked in homeless services in Brighton and Hove for the last 14 years. She now manages the health engagement team outreach team who work with people in emergency accommodation with complex health needs. And she also manages various other co-located health engagement services across the city. So you're going to be hearing later on from all of them about the work that they're doing down in Brighton. I'm just going to start off by giving you guys a little overview of today's session. I'm assuming my screen is sharing okay. Please let me know if it's not. So we're going to start off with a presentation on the Homeless and Inclusion Health Barometer, which I'll give you a bit more information about shortly. It's a research report that we produced at Pathway. We're then going to have a first panel discussion where we're going to get some reflections from the panel on what I've presented on, and then also be an opportunity for you to send in your questions in the Q&A. So if you do have any questions at any point, please put them in the chat and we'll get through as many as we can. Following that, we're going to have 25 minutes of presentations from the services that I've just mentioned. You're going to hear about how they're responding to these challenges, the work that they're doing down in Brighton. And then we'll close with another panel discussion and also the opportunity for you to ask any specific questions you would like to those services and around those service presentations. So the first half is going to be a bit more focused on the sort of challenges that we see, looking at some of the difficult outcomes that we're working with. And hopefully the second half of the presentation is going to be a little bit more optimistic, thinking about how we can collectively respond to these sorts of challenges as well. So starting off with the Homeless and Inclusion Health Barometer, to give you a bit of background about what this report was, it was a report that we produced at Pathway in collaboration with Crisis. We were essentially trying to bring together lots of the different available evidence around homeless and inclusion health to highlight where the key challenges are, but also really to highlight what the opportunities are moving forward, where we need to see improvements most drastically as well. And the point of bringing this evidence together into one document is to have a resource that we can use to influence decision makers, if that's in NHS England, central government, local government, or ICSs and ICBs. They are integrated care systems and integrated care boards, for anyone who might not be aware, which are essentially local health commissioning bodies as well. So we really wanted to pull all of this evidence together, highlight what needs to be done, and be able to use this to influence the system in the direction we want to see it changing. Just a really quick note on the phrase inclusion health. There's probably a lot of you watching who are aware of this phrase, but for anyone who's not, it is essentially an umbrella term for socially excluded groups that experience extremely poor health outcomes. You can see underneath some of the groups we typically talk about when we use the phrase inclusion health. Couple of things to say. Firstly, there's a lot of overlap between these groups. They're not distinct groups. There are also some important differences between these groups. For example, experiencing homelessness is a temporary state that somebody can find themselves in, whereas aroma ethnicity is a permanent trait about a person. So there's a lot of overlap, but there are also some important differences that we need to account for as well. Really, these groups are united by, firstly, the kind of poor health outcomes and the access to healthcare. There are also shared experiences of housing instability, experiences of trauma, whether that's childhood trauma related to migration, and also experiences of deep, deep social exclusion, which includes experiences of stigma as well. So when I use the phrase inclusion health populations, I'm very broadly referring to these groups who have some differences, but also have these very shared experiences as well. A quick note on the methodology of the barometer. So these are essentially the different sources of evidence that we pulled from. Firstly, we did a bit of a literature review. So we looked at 85 UK-based research reports. We pulled some key data from Spotlight, which is an online data platform developed by the Office for Health Improvement and Disparities. Essentially presents some of the available public stats around inclusion health populations. Even though the data is quite limited, it's quite a useful resource. We also looked at pathway needs assessments. So these are assessments we do at Pathway where we look at specific hospital systems, we identify specific challenges within those systems, and we help healthcare commissioners design services that actually meet their local needs. And we also conducted a survey of the Faculty for Homeless and Inclusion Health. So this is a national network of around 3,000 people who are all working in or interested in inclusion health. So we developed a survey to capture their views and perspectives on some kind of key topics that we're interested in. So we essentially looked at all these bits of evidence, we thematically analysed them, and we presented them in the report. I just want to say that what I'm going to present today are some very high-level thematic findings. There is a lot more detail in the report, and I'll make sure everyone who's attending gets a link to the full report as well if you want to take a look in more detail. To start off with a bit of background context, and this is going to be very, very familiar to everyone who's attending today's session. So firstly, we have the crisis within healthcare. So the NHS being under extreme pressure and the general public are really struggling to access healthcare as well. Public satisfaction reaching record lows. And obviously, we're all aware we are facing a national housing crisis. One of the results of this is that we're seeing rising numbers of people experiencing homelessness, whether that's rough sleeping, sofa surfing, record numbers of people in temporary accommodation. And what we find for inclusion health populations is that they're really caught in the middle of these two crises. So they struggle to access healthcare, they struggle to access housing. And because of the housing crisis and the healthcare crisis, more and more people are falling into that kind of inclusion health category. We also want to make the point in the report that these crises are being driven by a combination of policy choice and inaction. There is an endless list of things to go through. I've just pulled out some kind of key ones there. We're trying to make the point that these crises, and especially how they affect our populations, are completely avoidable and are the result of deliberate, sometimes policy choices. One of the first key findings we highlight in the report is that the pressure on the NHS is really making things harder for inclusion health groups to access healthcare. And this is happening in a few different ways. Firstly, the pressure is making services less flexible. So, for example, they'll be quicker to take someone off the caseload if they miss an appointment. This is really problematic because all of the evidence for inclusion health says you need to have a flexible, pragmatic, and holistic approach to actually meeting their healthcare needs. So this pressure is making services less flexible, which makes it harder for people to access them. We're also seeing that services are increasing their thresholds for access. So this means that when people reach services, they're often at a point of crisis where they have multiple health needs, overlapping and complex health needs. And this is a really big problem because healthcare services are not really designed to actually meet this kind of complexity of need. They're very often designed to meet specific needs. So when people present with these really complex combinations of needs, services aren't able to effectively respond. And we're also seeing that the pressure is driving a shift to digital service provision. You know, you need internet access sometimes just to be able to book an appointment nowadays. And obviously for people who struggle to access the internet or phones, this further excludes them from healthcare services. There's a nice quote from the survey. So pressure means that services are less flexible when people do not attend, arrive late, or exhibit difficult behavior. One of the key points we want to pull out in the report is around stigma and discrimination, because this came up time and time again across all of the different bits of research we looked at as being a major barrier for these groups to actually access care. So firstly, 85% of our survey respondents said that this was a barrier to these groups accessing care. All of the research we looked at, it indicates this plays out in a couple of different ways. Firstly, when people experience stigma, it really affects their confidence and trust in service providers. So they therefore find it hard to engage with their own healthcare because they're concerned about how they might be made to feel, how they might be treated. So that's a huge problem. We also find that when healthcare staff do have stigmatizing attitudes, it prevents them delivering care in a kind of thorough, person-centered and compassionate manner. So not fully understanding people's needs, not being willing to fully assess people's needs as well. So stigma really being a huge barrier to accessing healthcare. We're also making the point that this seems to be the case across all healthcare and statutory service settings as well. This is really across the board. And I think really crucially, some of the research that looks into this shows that it's very underpinned by a lack of understanding about how people ended up in these situations, what their needs are, the kinds of experiences they've had. And I think we're going to hear a little bit more about this later, but education clearly has a really important role to play in actually challenging stigma and improving attitudes. A couple of quotes from the survey just highlighting that, so affecting people's confidence to approach service providers. And very commonly, we heard this from a lot of people, patients are blamed for their situations rather than shown understanding. We also identified lots of additional barriers that face migrants, refugees, and asylum seekers on top of what I've just talked about. Firstly, is the no recourse to public funds designation, which we're all aware is extremely challenging for people to access the support they need, in particularly around housing as well. Language issues can make it very hard to understand the healthcare system, and there's a lack of kind of translated information or translators to actually support people to go through the healthcare system. A lot of asylum accommodation can be very prohibitive to accessing healthcare. For example, there might not be any services nearby, or when people are frequently moved between different accommodations, they'll find it very hard to access the services they need to. And for many migrants, there will be fears that they will be actually charged for accessing healthcare services. And for many undocumented migrants, there are fears that they'll be reported to the Home Office as well. So people won't even try and engage with healthcare services because they are afraid of these outcomes. We're really trying to make the point in the report that this is not a failure of any one specific type of healthcare service in the mainstream. It's really across the board, and this is a systemic failure to meet the needs of these groups of people. So this chart was taken from the survey. We asked people to rank how easy they think it is for people to access different types of healthcare services. None of the services we asked about had more than 30% of people saying they were easy to access. So you can see the problems across the board. Dentistry, mental health, and mainstream primary care really highlighted as being kind of the most challenging parts of the system for these groups of people to access. We're also highlighting that there seems to be a failure of key statutory services to meet the needs of these populations as well. So obviously you need the healthcare system to play its role. We're trying to make the point that you also need these other statutory services to play a key role. As you can see from the chart, people in the survey generally disagreed very strongly that these services are meeting the needs of people in inclusion health groups. So housing, a pathway, we very often say there's no health without housing, and this is really fundamental. If you don't have somewhere safe and appropriate to go to, how are you supposed to recover from whatever conditions that you're experiencing? So obviously a lot of you will be aware about the general issues with temporary accommodation, just the lack of provision, the difficulties even getting a placement for people. What we also saw from the research was that temporary accommodation is actively detrimental to people's health, to people's physical health, to people's mental health as well. And we're also seeing that it can really limit access to services. People can be placed out of area, people can be moved around, and this makes it very hard for them to access the services they need. The research also shows there's a lack of more specialist supported accommodation as well for people with more complex needs. So there's a real gap with the housing provision for these groups. In terms of safeguarding and adult social care, I mean, obviously these are services which are under so much pressure, under-resourced and underfunded, which is important to consider. Generally, these services are also not meeting the needs of people in inclusion health groups as well. A lot of things pointing to kind of delayed responses, inadequate assessments, and a general kind of failure to engage with these populations of people. There's a good quote to sum it up. Safeguarding concerns are only dealt with in a timely manner if there is professional shouting from the rooftops. One of the areas we wanted to highlight, this is an area where all of these things kind of come together, and this really highlights the kind of the systemic nature of the failure is around hospital discharge, where you need healthcare input, you need housing input, very often you need social care and safeguarding input as well. What we're seeing is that hospital discharges are really, really poor for people in inclusion health groups. So taken from the survey, firstly, we had 75% of people saying people are often or all the time discharged with unmet health needs. And we had 50% of people saying that people are often discharged to the street as well. So this is a complete failure of care. And obviously, being discharged from hospital, to an inadequate location or to the street and with unmet health needs, there is almost no chance for recovery. So people end up in this cycle of engaging with usually emergency services in hospital rather than getting the care and ongoing support that they need. So this is an area we're trying to highlight as a kind of key failure of the system with really negative impacts as well. As a result of all of this, this limited access and all of these issues with people getting the care they need, all of the data and the research points to the very unfortunate points that outcomes are poor and they seem to be getting worse. So firstly, mortality amongst people experiencing homelessness has been rising for a number of years. The ONS reporting 741 deaths in 2021. You can see there's a really big increase there. The Museum of Homelessness, which are a really amazing organization, they use a slightly different methodology. They estimate 779 in 2021 and 951 in 2022. So obviously there's really shocking figures. And a lot of other data we looked at just shows the incredible complexity of physical health, mental health, and substance misuse needs amongst this population as well. We asked people from the survey what they thought about the health outcomes for people in inclusion health groups over the past 3 years. Nearly 60% said that they'd worsened. And when we asked them what they thought about the complexity of need amongst these groups, 80% said that the complexity of need had actually increased over the past 3 years as well. So we're really seeing a challenging picture. Things seem to be getting worse in some ways. One of the other key points we wanted to draw out in the report is around the relationship between specialist and mainstream services. So we find ourselves very often caught in this debate between, do we need to have more specialist services or do we need to improve the mainstream? We're really trying to drive home the point that you absolutely need both. Yes, we do need more specialist services, but we also need to see dramatic improvements in the mainstream as well. All of the people we talk to who work in specialist services through the survey and a lot of the research around this topic shows that specialist services can achieve really positive outcomes, and we're going to hear about that later on as well. But a lot of people express the sentiment that the extent that they can achieve is really constrained by the limitations within mainstream health and within statutory services as well. So all of this amazing work can happen without the kind of effective input from the mainstream. We can only kind of achieve so much as well. You can see from the chart on the right that there are very low levels of specialist service provision, very small numbers of people saying there's actually enough of this provision as well. Increasing demand is a challenge, inadequate resources, and a lot of people saying that they actually find their work stressful. One of the key reasons for that was an inability to help people due to those issues with the mainstream services as well. So that's a really key point we're trying to drive home in this report. I think this quote really sums it up nicely. We do our best and have things to celebrate, but we are simply tinkering with the shop window. There is very little in the shop itself. I do want to end on a slightly more positive note because this is all very challenging, and this is a realistic picture of where we're at, and it's important to understand the scale of the challenge and what's actually going on as best we can. But it is important to highlight some of the more positive things as well. So we have quite a lot of examples in the report. I've just pulled out a few for you today. Firstly, around trauma-informed care and psychologically informed environments. So we're seeing a growing body of evidence about the effectiveness of these approaches, and we're seeing them being implemented in more and more places as well. And we're going to hear a little bit about that later on as well. It's been shown that this can be beneficial for service users, for staff, and is generally very positive. So that's one thing which is good. There have also been a couple of really important pieces of research over the past year. Firstly, we had an evaluation of specialist intermediate care, and secondly, an evaluation of specialist primary care. Both of these showing that these services are really effective and they're cost effective as well. So that's some really important evidence for us to be able to make the case for these specialist services. We are also seeing that inclusion health is moving up the kind of national strategic agenda. So we have the NHS framework on inclusion health, and we have the National Institute of Care Excellence guidelines on inclusion health as well. So that is really positive to see it being recognized within these larger national structures. However, we are trying to make the point that in order for these frameworks to be effective and these guidelines to be met, we need to see dramatic improvements in a lot of areas as well. And finally, we are seeing increasing engagement from ICSs, so integrated care systems, with inclusion health. A growing number of ICSs are developing local inclusion health strategies and thinking about how they can kind of effectively meet the needs of these populations. So I'm going to stop sharing now, and I'm going to take a look at the Q&A. We'll come to the questions in there in a moment. Firstly, I'd just like to come to the panel, and I'd love to get your thoughts and reflections on what I've presented. In particular, I'm kind of interested in a few different things. Firstly, around the kind of increasing complexity and the worsening outcomes. Is that something you're seeing in your local areas? Is this match up with your experience? It'd be really interesting to hear about that kind of relationship between specialist and mainstream as well. And interesting to hear about, although we're saying this is a kind of systemic failure, are there any particular areas of care that you think are, in dire need of improvement, where the biggest kinds of challenges are as well? So Hannah, I'm going to come to you first.
Thanks, Theo. Thanks for that presentation as well. That is great, and great to see your report presented in that way. And I think we contributed to that survey as well, so it's good to see the outcomes of that. Thank you. I think the first thing I was thinking about was, the relationship between mainstream and specialist services and how tricky that interface is at times as well. And I think as a specialist service ourselves, we spend a lot of time trying to bridge the gap between the services that we are able to provide and those that we are not, and that patients have to attend mainstream services for. So, I'm thinking particularly around specialist diabetes services, for example, or secondary care at the hospital in different departments. And I think, one of the things that we end up doing a lot of is we have quite a big admin team, and we have that because we do a lot of checking in with patients to try and help them to engage with those appointments. We do a lot of checking in with mainstream services to apologise and advocate for missed appointments, and please don't discharge them, and please can you see them again, and please could you contact the support worker instead of the patient directly, or could you inform us all so we can try and support. We spend a lot of time doing those sorts of tasks to try and bridge that gap between the specialist and mainstream services. And I think that's something that we're just doing more and more of. And as you highlighted in your report, the threshold for services is getting higher and higher, but also the cutoff for discharging is getting lower and lower as well. So, that's becoming more and more of a problem, as well as waiting lists and waiting times, those sort of things. We spend a lot of time checking people are still on waiting lists, reassuring patients that they're on waiting lists, going back, trying to expedite things where we can, that sort of thing. So that is still a big gap, and it's still the case that patients end up not receiving the care and going back to the bottom of the list, and off we go round again. So that's my initial thoughts. Firstly, I could go on, but maybe I'll pass over to Jules and Sara to add some thoughts on that point.
Yeah, thank you so much.
Sarah, you're probably best placed for this one. Sure, yeah. I mean, this is part of the whole piece of work that my team does alongside Hannah's service, is lots of the time supporting people to access inclusion health services can be quite straightforward. They're often people that we know within services that kind of fit within the way we work. But when we're taking people to mainstream services, and without any kind of thing against any other clinicians, it's a roll of the dice. You don't know. You might get someone who's brilliant, and that honestly does happen. That you come out and you're like, wow, that consultant talked really well to the client. The engagement was really good. They explained things really clearly. and sometimes it's terrible and you really just don't know. So lots of the work that my team does is take people to appointments, be on the journey with them, talking about what type of things might we want to ask them, how might we manage this conversation together, have the conversation with the clinician, and then debrief afterwards. And by being in it with someone, you can try and learn yourself so that you can help the patient understand better, because often they're really quick appointments, and that's just because the clinicians got to get through them. All the, when you've got 10 minutes or whatever to have this whole appointment for someone's like major issue. And lots of the time we work as sort of translators almost in that space of like, it's okay, I'll explain later what he means, we'll just get this conversation done with, because they're very difficult spaces for everybody, particularly people with any sort of barriers around challenging behaviour or anything like that. People can be very sort of written off quickly, and often things like mainstream services are more likely to do things like talk to the worker and the professional, not the client, not the patient, or use difficult language that maybe neither of us understand, that we need to kind of have explained. So yeah, I think with inclusion health services, it's kind of, we know that stuff, we know like communication barriers and things, we're taught about those things. But I think in mainstream, because you're dealing with every type of person everywhere, the kind of particular skills that you need to communicate with people with complex needs aren't always there.
Yeah, I guess just to add from a lived experience perspective, so I work with a steering group of about 10 to 15 people with lived experience of homelessness, and a big part of our work was kind of mapping inclusion health, or mapping the health system in Brighton. And from that, we kind of came up with 13 challenges that people explored within the local healthcare system. This is just Brighton. And these all kind of match up really nicely with the report and what Sara and Hannah are saying. For example, people were talking about how there's a lack of trust in services, how they're not joined up, how there are long waiting lists. This is very much kind of lived experience perspective. They weren't asked any questions. It was very kind of blue sky thinking of what are the current issues in homeless healthcare, and it's very much in line with what's happening and with the report.
Yeah, and it's like this thing sounds particularly challenging about this, as you say, this kind of roll of the dice, and really people not knowing, is it going to be a positive response? And I guess for you guys trying to interface with those services, you're kind of unsure about what level of engagement you're going to have to put in at any given one moment. So that sounds like very uncertain. I mean, I think a kind of key point within all of this is around kind of education as well. And when we've kind of looked into this as part of this survey, we had a lot of people working in mainstream healthcare services who responded to it, and we were interested in the kind of level of training there was around issues in inclusion health and, for homeless populations, whatever it might be. And we found that the level of training was unsurprisingly extremely low. We were also asking people about why this was the case, and a lot of people simply saying that they didn't find this training to be available, they didn't know where to find it or how to access it as well. Obviously, these are people who are already interested in inclusion health, that's how they were responding to the survey. But even those people really unsure where to find this training. So I'm just interested to hear about, do any of you have any experiences in kind of delivering that education piece, and how that's kind of affected your relationship with some mainstream services as well?
Yes, so I'll probably go into a bit more detail during my presentation. So the Brighton and Hove Common Ambition project produce a second-year medical student training on inclusion health, which I'll go into more detail about. But the whole idea of that, it was co-produced and led by people with lived experience of homelessness and the homeless healthcare system. And Dr. Kate Pitt, also from Arch Healthcare, delivered that training. And it was really well received. I guess the limitation of that, it was quite a small cohort of people. It was an optional module at Brighton and Hove Medical School, but we're kind of hoping to roll it out further and then kind of really see how much more work we can do with the local medical school in Brighton, hopefully with a view to maybe doing a lecture. It looks like that's in the works as well. So kind of trying to roll out more education in terms of training. A lot of this was around mental health, was around stigma and judgment as well, and kind of challenging preconceptions of homelessness, which I'll probably repeat in my presentation.
Also, I mean, I've taught on some of the stuff with Dr. Kate and a few other bits, and then there is a definite like want for it. We did a session around substance misuse for people who were training to be GPs, and they were just things like they didn't know about drug and alcohol services because literally nobody tells you. No one teaches you. And I was just talking about like, oh, it's helpful to like know what the service looks like. What does it mean when you explain to somebody, I've referred you to this? How can you tell them what might happen? And just some teaching about that really basic stuff, just so you can have the conversation with the patient and know what you mean. Because I think like when you're looking at that clinically, you're just saying, oh, you move on to a different service, I refer you to something else. And actually, the likeliness of someone engaging with that is much higher if you can talk to them about what it means, what it looks like, what questions you might get asked, what might the outcome be. And so, yeah, we did a bit of teaching at the university for people who are already qualified, but like looking to specialise in being GPs around that kind of stuff. I mean, it's a drop in the ocean. It was just a kind of one-off, but looking to do more of that sort of stuff, of what do things look like on the ground for this patient group. And if we can explain it clearer, if we can be more honest about how it looks and what the outcomes might be, people are going to be more inclined to engage with it. And then they might think, oh, I am going to have to wait because I got told I have to wait. You know, just things like that. If we can be clearer about what the process looks like.
Kind of demystifying, really.
Yeah, I mean, I made a joke in that session about how our drug and alcohol service is at the top of a hill. You've got loads of chat there. You can make some chat about that. You've got to walk up a massive hill. But these sorts of nuances and details that make it look like you trust that service, therefore it's okay, or you know about it, and people can have more of an understanding of what things are out there, and oh, my doctor says it's good, so it might be okay, that kind of thing.
And I wanted to ask as well, just on the point that I made about this kind of increasing complexity of needs that people perceive. Is this something you guys are also seeing? And if so, are there any particular perhaps conditions or any kind of combinations of needs that you're seeing kind of particular increases in? Is it kind of across the board? It'd just be really interesting to hear about your experience on that kind of increasing complexity of healthcare and support needs as well. Hannah, I'll come to you first.
Yeah, sure. So I think in terms of increasing needs, things that we're seeing here in Brighton, and I don't know if this is an increasing need or if we've started to pay more attention to, is our alcoholic liver disease patients, and trying to create more support and pathways around their care. So these are, you know, our chronic drinkers who bob along quite well for quite a number of years, but there's gradually a decline, and you know, it's picking up those signs and cues earlier. And I think that's something that we're trying to focus on as a service, is finding ways to do that better, and linking in with our colleagues in secondary care as well around, you know, patients that are admitted with alcoholic liver disease or decompensating liver disease, those sorts of conditions that, you know, they end up with an admission and a discharge. And then how do we kind of intervene and work in the community around managing their health needs better? So we're seeing quite a lot of that. And I guess the age-old challenge of the co-occurring substance misuse and mental health issues, and you know, that's again, you know, challenges that we have around getting people care in those specialist services around mental health services, especially when there's co-occurring substance misuse. Yes, our local area has just employed 2 dual diagnosis nurses in mainstream services, which is, you know, is amazing, but still a drop in the ocean. But it's, yeah, that's an area that we're hoping we might be able to have some more inroads into, helping people get care in those areas.
Just to come in on the dual diagnosis point, because in the report we do highlight this as a particularly challenging area. It'd be good to get your thoughts on this. All of the research we looked at and the survey, it seemed to highlight that for people who have dual diagnosis, so mental health and substance misuse problems, the bigger challenge is around them accessing the mental health support side of things, rather than the substance misuse side of things. A lot of the reasons for that were talked about, stigmatizing attitudes towards substance misuse, for example. So we kind of had this perception that but people with dual diagnosis, mental health support might be harder to access. Is that something you think is true? Does that match up with what you guys see?
Yeah, I would say that that is my experience as well. Is that it's there's often a knockback to our referrals that is like, we can't work with this person until their substance misuse is better managed, or until they've been free of substances for 3 months, then we will see them. Or and it's those are very difficult. How do you manage that? When they're co-occurring, you're not going to get a period of abstinence to monitor and to see. So it's those are, I would 100% agree that that's a challenge that we have locally.
Jules or Sarah, we're going to have to move on in a second, but if you want to share any final thoughts on what we've just been discussing about, please go ahead.
Yeah, I mean, in terms of higher needs, what we're finding in health engagement is that we get referrals from people who would otherwise have previously been served by other services. So people with higher level of learning disability, people who are care leavers, people who are young people, people who previously would have had other provision that isn't a homelessness service necessarily, would be a specialist service based on their need. We find the less and less we have of them, the more people are sort of sent into services that are focused around homelessness rather than their actual needs. And because we work with health and homelessness, they tend to come our way. And yeah, so that's an increase in demand on our service, when actually they are people whose needs would have previously been met elsewhere.
I guess, yeah, just one point on something slightly different. In terms of stigma and judgment, I think a key way to combat stigma and judgment is through kind of integrating lived experience voice into anything and everything we do, really. My final 2 pence.
Great. Thank you all so much for those thoughts and reflections. We're now going to move on to some presentations from the services, so a bit more detail about what's happening on the ground. Just before we do, I just want to say, Rosie, I have seen your question in the Q&A, so I'm going to come back to that one when we move into the final panel discussion and Q&A session. It's around people who are care leavers, so it touches on what Sarah's just mentioned as well. So over to the service presentations, and Jules, I believe you're going to kick us off.
So, hello everyone, I'm Jules. As Theo said, I'm one of 2 participation leads on the Brighton and Hove Common Ambition project. So our aim is to improve support systems in Brighton and Hove through co-production and advocating for lived experience voice to be central into service and systems change. So next slide, please. Thank you. So we started as a 3-year partnership project. Partners were Arch Health, represented here, and Justlife as well, University of Brighton, Brighton and Hove City Council Public Health Department, and NHS Sussex. And we were funded for 3 years by the Health Foundation. So the initial goal really was to focus on homeless healthcare in the city, and it was part of a kind of wider national Common Ambition programme, but we were the only one that focused on homelessness and health. The kind of key insight, which is in line with what Theo was saying, was you can't separate housing and healthcare. The two are kind of intrinsically linked. We're pleased to announce that we've received funding for another year, but we have a few new local system partners and we're working a bit differently. So do explore our website. Everything that I'm speaking about is on there. Everything is free resource as well, so have an explore of that. We kind of want to make sure that everything we have learned over this past 3 years is shared to everyone. So next slide, please, Tom. So very much in line with the report. So our lived experience steering group that meet about once or twice a week started off by identifying some key challenges within the homeless healthcare system. And we kind of whittled them down to 3 key challenge areas. And they were barriers to accessing care, continuity of care along the pathway. So we found that when someone might be in council accommodation, for example, a lot of care will then drop off. Facing stigma and judgment, lack of mental health support was a challenge in and of itself. And then training capacity for staff. So again, very much in line with what the report was saying, is some of the work that we did, just very different methodology, I guess. And here are some of the quotes from some of our members. Next slide, please. So a bit of an overview of our impact for the past 3 years. We created a voice for people with experience of homelessness and multiple and compound needs in the city, which otherwise didn't exist. It took a long time and a lot of patience and resource to kind of build that group and to do it safely and to ensure that it wasn't tokenistic and that it was safe the whole way through. There was a bit of trial and error as well, as there always is with kind of new projects. So we developed a work and learning pathway for members, so they can kind of go, they learn a lot of skills and gain a lot of experience through the project, and then they can kind of go on to other different places, which was an unexpected impact actually, and definitely one of my favourites. We developed a unique trauma-informed approach that was very much unique to the project and our work. Again, this can all be found on our website if you want to learn more about it. So we mapped and identified the barriers within the system and pathways. So we kind of found very early on that there was no one place to learn about the system. So we kind of had to understand and just define the system before we could kind of do any service design or any kind of service improvement work. So we created various maps to do that. And then from that, we were able to identify barriers and challenges. We co-produced all of our processes and guidance, our communications, the website that the group really wanted to have that is actually very useful now. And we've put on lots of events for the city to kind of invite them to view our work and engage with some of the things that we're doing. So in terms of service and systems improvement, they took the form of what we called 15 co-production design sprints. They were kind of specific piece of work targeted on following our system challenges. So they included developing a training for medical students, mapping the local housing pathway, so from single adult perspective in the local system when someone is experiencing homelessness to when someone is housed, because we found that was a big challenge, just like what is the system? How does someone navigate through the local services? Co-producing research with our university team, developing a homeless healthcare hub specification, co-producing a comic to raise awareness of some of the challenges that people face in the local system. So these are just some of the design sprints that we did, that are highlighted. Next slide, please. So as I spoke about already, one of our quite interesting pieces of work was co-producing medical student training. So this was an optional homelessness and health course for second-year medical students at the Brighton and Hove Medical School. So this was co-designed with Dr. Kate Pitt and the Lived Experience steering group in November 2022. And the initial design was delivered in 2023, in January 23. And now it's also going to run every term, which is quite exciting. And then after the first piece of after the first bit of training was delivered, we got a lot of feedback from the students, and actually they came in and met our steering group as well. So we kind of incorporated feedback into the design and the delivery of it. We work in quite a creative way, and we try and get as much reflection as possible and feedback into some of the work that we did. So it was very important that we meet the students who've done it to ensure that we were meeting their needs. And I think a big part of this kind of highlighted very new, different ways of working. So in terms of, we ensured that we built trusted relationships with the students, with each other. We made joint decisions. We co-developed all the processes for this medical student training, ensured that the space was safe. I think a big part of it was preparing clinicians and students who don't normally work in a homelessness health setting, and kind of gently challenge ways of working and certain misconceptions and preconceptions that people might have about people experiencing homelessness. And a big part of how we wanted it to be delivered was to model trauma-informed working throughout the whole course as well, because we work in a trauma-informed way. We wanted to ensure that students felt safe as well. So an interesting part of this that came out quite naturally, which is on our website, is we created a case study guidance. So this, we kind of unpicked the ethics of case studies and how can we create a case study from a lived experience perspective that ensures that someone has ownership of their story, for example. Yeah, so that can be found on the website as well. Next slide, please. Another service design sprint that we co-produced was a homeless healthcare hub, which probably isn't a new idea to everyone. It's kind of been around for a while, but this is specified and designed by people with lived experience of homeless healthcare. And a lot of the evidence that we gathered from kind of mapping our challenges pointed to the need of a kind of a physical space where people could go to have their needs met. So within this specification, it's around we went blue sky and we went big with it, because why not? And people can kind of pick and choose parts of it if they want to, if they can afford it. So under this specification, we spoke about having an information hub, so information where we can get all information, all the local city services. People can have access to IT, to phones. We could have frontline services under one roof, and this can take various different forms, so that people can physically go there to have meet all their support workers. It could be a learning hub, so a space where people can do training and research. And then finally, it could be a bit of a community hub for people in the local area. I think a big part of this is to ensure that there is lived experience representation within the planning of this, and also the delivery of it, as well as the governance of this future hub that might exist one day, who knows. So Sussex ICB actually used this specification as evidence for council leaders, which has now made it a priority as part of their new housing strategy, which is very exciting. And yeah, I think that's, a lot of people have thought about this idea, but this is very much for a lived experience perspective. So next slide, please. So finally, we thought we'd give just some kind of top tips in co-production for anyone who might be interested in kind of doing some of this lived experience work. Again, there is more detailed versions of this on our website. So I think an important point to make is that co-producing improvements and system change can break down barriers and misconceptions and provide really valuable insights to how we do our work and how we do systems improvement work. One of our members has said, you won't be able to see what we can see, which is kind of the crux of it, really. So a few kind of top tips. Safety must come first. My role is predominantly to ensure that all members are safe all the time, and to kind of help build that trauma-informed practice, and ensure that members are safe given their kind of potential levels of complex trauma that they might have experienced while experiencing homelessness. It takes time. It takes time to build trust. It takes time to build relationships. We are very lucky that we had kind of funding to do it slowly. And we can kind of learn together, and we became experts in homeless healthcare together, which kind of helped balance out that power a little bit as well. All of our processes were co-created to ensure that the space was accessible to everyone and how they wanted it. Support people to co-produce. And then finally, reciprocity is key in co-production. So we paid our members for the work and for the engagement that they contributed on the project. So yeah, thank you.
Jules, thank you so much. Really great to hear about all of that work. And I'd love to, when we come to the discussion, ask a little bit more about the co-production side of things. Also, the Homeless Health Hub sounds like a fantastic idea as well. Really getting those barriers down, making it more accessible for people. Sara, we're going to come to you next.
Great, lovely. Thanks. I'm just going to move my chair and it's really loud. Hi, so I'm Sara. I'm the team lead of the health engagement team at Justlife. So health engagement is outreach workers who work with people in emergency and temporary accommodation, particularly with people with complex and unmet health needs. So our aim is always within Justlife to think about emergency accommodation and people's experience of that. But we do this alongside this inclusion health role. So we work with people who are in emergency placements. We know their place there, their priority needs, they have additional needs on top of their homelessness, and particularly around their health. That's where we kind of are able to support people, because we're accessing healthcare. people in emergency accommodation. So we kind of go through, oh, next slide, please. Because our aim is always to try and make people's experience of emergency accommodation as short, safe and healthy as possible. And here's a bit about kind of how we do that. So there's 5 staff on our team, on the main core health engagement team. We have various specialisms. We have someone that specialist to work with women, somebody specialisms to work with mental health, and other bits and bobs. We also have other posts that are co-located and do a slightly different role, but all kind of come under this health engagement stuff. So we have somebody in A&E who's works with rough sleepers. So rough sleepers presenting to A&E, and then he works to work out if they would be placed. He would do that bit of work. They either go into hospital and then come under pathway, or he looks at seeing if they're able to be housed as a result of their health needs that they're presenting to A&E with. We have someone employed by the Hep C Trust via Justlife who supports people who are got problematic drink issues to have their liver scanned, and 2 posts in Changing Futures. So we're kind of part of being as involved with other services as much as possible to integrate this idea of inclusion health and accessing both homeless services and healthcare simultaneously. So it's intensive non-clinical support from us. None of us are clinicians. We kind of act like an outreach team within homeless services that would be quite familiar to you, but we do it with this kind of health edge. So we know lots about health needs, lots of the kind of things that we see really regularly, and we can kind of talk about them quite easily because we see them a lot, but we're not clinicians. This assertive outreach model, I'm sure lots of people watching this also use assertive outreach models, but if anyone who doesn't know what that is, it's basically you're a professional pest. It's all about really trying to engage people, really encouraging people. We work with people who might have not accessed healthcare for a really long time, very suspicious of services, may have had no safe adults in their lives. We kind of turn up as strangers, and we want to respect that and think that somebody might think, I'm not sure who you are for a while. So kind of work on building trust, trying to meet people's immediate needs where we can, trying to encourage people that we are somebody they can trust who will help them access healthcare. So yeah, that's kind of assertive outreach model because we work with people with multiple compound needs who might not be easily able to access services. It's a multi-agency with both homelessness and specialist health services. So we work a lot with Arch. We're funded by Arch. We also work in homelessness, same as before. So and we look at advocacy around appropriate move on for emergency accommodation. So we know that emergency accommodation doesn't meet the needs of lots of the people who live in it. So we would look to try and advocate as much as possible to have people moved on as soon as possible from it. And we get to know the people that we work with really well, so we would know the housing system and what suits them, and then try and advocate for move on into places that we feel like somebody might do really well in and be able to get better in. Funded by a local homelessness GP surgery, that's Arch, I mentioned that. Next slide, please. Oh, here's Jules. How does it fit with inclusion health services? So we sit between both. We sort of shimmy somewhere in the middle. Lots of the work we do is around someone's health. So we're always trying to identify what their health needs are and how might we look at trying to meet that need. Lots of the time we coordinate every part of someone's healthcare. We book the appointments, we remind someone, we pick them up, we go with them, we're in the appointments, we book the follow-up. We're kind of part of everything. We teach people how to collect the medication, how to take it, when to take it. So we do lots of these kind of health-related pieces of work. But simultaneously, we know that people aren't going to get better until they're appropriately housed. So we do all that kind of normal housing advocacy in the background. Next slide, please. So people always say, what kind of health needs do we mean? So I just thought it might be helpful to list some of the things that we come across. This is the sort of stuff that people might be referred to us with. Cancers, HIV, bloodborne viruses, wounds, particularly chronic wounds, chronic illnesses such as diabetes. And what we also find is old, poorly healed injuries or things that people have never addressed before. Lots of the time when we work with people who haven't accessed healthcare for a long time, it was never that they didn't need it. It was that there were things they had that they've never addressed. It might have been they had like maybe poor parenting that didn't teach them to to access healthcare, or it might just be that they never prioritised their own health over any of their other needs or someone else's needs. So lots of the time we work with things like poorly healed injuries that people haven't had looked at, particularly around poor or unaddressed mental health. So sometimes people don't identify these health needs themselves. Sometimes it takes a bit of learning. So that might be conversations around people telling you they experience pain and you saying, oh, you don't need to. We can look at getting that addressed, or people thinking, oh, I'm wasting the doctor's time. I don't need to go there. So and actually teaching people that everybody deserves to access healthcare. So lots of stuff around that. The types of interventions are sort of things I've mentioned, organising every step of an appointment. We're always working towards independence. Our plan isn't to do that forever, but once you know a space, you might be more inclined to go yourself. So by teaching people that the receptionist's friendly, you know where the front door is, you've met the doctor a few times, it's not that scary, or like, you get used to going to a place. It's building up that independence and that confidence and the idea that, yes, I can go, I can take up space there, I do deserve that, and I am able to. So we're always thinking about how do we support people to get more independent in accessing healthcare. We also do things like coordinate end-of-life care and advocating around mobility needs. Mobility needs are extremely difficult within housing, so we're always trying to look at how people can be appropriately housed when they have poor mobility. Next slide, please. I actually don't know what any of these slides say, so they're a surprise to me. So there are challenges in all these things. I think sometimes it can be unhelpful to hear all the glorious work in a different area to wherever you are, but we're all facing the same challenges. So we used to be a bigger team, we're now smaller, the needs we see are higher, sourcing appropriate accommodation is extremely difficult. Brighton's a very tricky place around housing, everything's very expensive. We're finding it harder and harder for people getting placed because the amount of placements being offered is lower. And appropriate move-ons for things such as care homes or mobility appropriate placements are extremely difficult. So it's probably all the same things you see in your area. We're seeing it too. It's just also very tricky around health needs. Next slide, please. So thinking about that idea of like, if you are in an area that doesn't have inclusion health services, what can you do? And these are just a few things that health engagement does that you probably do anyway in your service, but just things to consider when you're thinking about advocating for someone's health is to always ensure someone is registered at a GP. Registering at GP can help everything, helps your housing, helps evidence, helps people access healthcare, but it's not correct that you need ID to register at a GP. And you might need to do some advocating around that because your local GP service may say otherwise. But it's important that everybody's able to access primary care. Prioritise your client's priorities or the person that you're working with's priorities. They might not be as obvious, but take their lead. We always find that it works much better. If someone's got a really niggling pain and it's bothering them, but you think something else is more important, they're much less likely to engage with it. Listen to the bit that somebody is experiencing more or sees as their own priority. Once that's dealt with, they'd be more inclined to deal with the thing that you want to look at. So think about what is their priority. Consider meeting places around what people's needs are, where people can best communicate. That will completely depend on what your working environment is, but some spaces people find difficult to communicate in. Be persistent. Health might not be on someone's agenda. It might be that someone's never given it any thought, and they just think this is their what they have to live with. So keep bringing it up. Keep having conversations around health. Attend appointments with people as much as possible. So I mentioned this earlier, this idea of being on the journey to the appointment, in the appointment and afterwards as much as possible, because preparing someone for the appointment, what might we ask the doctor, what we're going to say, they haven't got much time. So we need to think about how people can best communicate what their needs are. And then afterwards, having that like, oh, this is what they said, you can remind people how the appointment went. Support people to understand their health needs as much as possible. So lots of the time you might be in the appointment learning it as well. So you're both learning together about that health need. And that can be really helpful. It's a kind of sort of co-production style of working, like you're both learning about what someone's needs are together. And so you can ask questions and you can help them learn as well. And it also helps support independence. As much as someone can understand about their health, the better, particularly around what medication they take, why do they take it, what does it do? The more people understand that, the less you're needed to kind of put those things in place. So the thing about health is it's really helpful around housing, to evidence it, to get it. It's also really helpful to help maintain it. People who are able to address their health, be healthier, generally are able to sustain their accommodation better, and the accommodation they're in, even if it's poor, can be easier to manage if your health is improved. So yeah, sorry if I went over time. That's my bit.
Thank you so much, Sarah. I mean, this sounds like such a fantastic kind of collaborative service integrating health and housing in the way that we know is needed. I think also that helping people to actually value their own health and understand their healthcare needs is such an important piece of it as well. So that was really interesting to hear about. Last but not least, we have Hannah. I apologize, Hannah, you might be a little bit squeezed for time because I'd like some discussion time at the end, but over to you.
Sure, that's great. I think my job today was really to give an overview of the rest of the services that we have and how they kind of relate to each other. Oh dear, I've got a thing saying things unexpectedly quit.
We can hear you still. You seem
Okay.
to be, yeah.
All right, hopefully that's fine. Okay, so I've just got a couple of slides which just outline the other services that we have here in Brighton. And just to say, it feels like we have a wealth of services here, and I think we do. There is a lot of people involved in working with people experiencing homelessness and in inclusion health here in Brighton. But it did start 25 years ago. It hasn't all happened overnight. Our very first, Brighton Homeless Healthcare, as we used to be called, the GP practice, started 25 years ago. So it's been building since then as we've been identifying need and resources to be able to provide these services. So just on this slide we've got a few things, and then there's just one more slide. So I should have done this in chronological order, but I haven't. But I'm going to speak about them in chronological order. So start with Arch Healthcare. So this was the start. This was a GP surgery, as I say, started in 1999 by Dr. Chris Sargent. It was a small service funded by the PCT at the time, and had a handful of patients at the time as well. And that's gradually grown. In 2017, Arch Healthcare won the contract, the APM Master contract, to take over that service, and we've been running it ever since. Arch is basically the directors of Arch. I'm one of them. We were basically the team that were working here anyway. We got together and managed to create a community interest company to take it on, and that's where that came from. So we were all here already, pretty much, and then we became Arch in 2017. So then going earlier in 2012, we had a pilot of the Pathway team. Again, this was a Dr. Chris Sargent experiment that he was involved in, and that was a research project around, it'd been started in London, and then we were a second site to see if the model worked here as well. And that was around, I'm sure you're all aware, the Pathway model, about working with patients in hospital and supporting them with safe discharge from hospital. So that started off as a 1-year pilot, and then we were funded for a second year. And then out of that second year, there was a piece of funding from I think it was called the Prime Minister's Fund of David Cameron at the time. And that was to fund a project that we called at the time Pathway Plus, which later became the health engagement work that Sarah's talked about. So that was initially about supporting patients that had been discharged from hospital in the community to help them to not return to hospital, and also to keep their accommodation and those sorts of things. And that has gradually evolved into the health engagement work that Sara delivers now. So that was actually, that's on the next slide, but you'll see that in a minute. So that's what came next. And then what came after that? Oh, if you could flick to the next slide, if that's okay. So then the Sussex Community Foundation Trust also came on board. They have a health inclusion team. It's a multidisciplinary team made up of nurses, OTs, physios, healthcare assistants, and a bit of admin. And they work across the hostels. They work a little bit like a district nursing team for people experiencing homelessness. They are a team that are, very happy and comfortable going into the hostels. They run little clinics in hostels. They do some really complex work with patients at end of life and complex illnesses. And they're an amazing team. They came around in about 2013, around the same time as the health engagement work started. And then if we flip back to the other slide, I really should have done this in order. Then came along the health engagement work in A&E. That's been a bit of a stop-start role as we've had funding. It's come from different funding pots along the way. And at the moment, it's a bit more securely funded. And that's around working with patients, as Sarah's already explained, in A&E who are presenting the patients that aren't going to be admitted but are homeless. And there's a lot of quick work needed to try and engage them with housing. Around 2021, we started our step down beds project. So this was funded through some of the out of hospital care budgets and some COVID recovery funds that were available at the time. And when we started, this is a project that we wanted to do for a long time, but we've not managed to secure the funding to do it. And this is started off as 5 beds. We've now got 7 beds in a hostel, and these are for patients coming out of hospital predominantly that have healthcare needs still. So it's funded around enabling earlier discharges from hospital, but actually which is great, but it is also providing a safe environment for patients to come out into, patients that might have some wound care needs post-operatively, for example, medication support, dealing with a new diagnosis of something that they need healthcare support with. Those sorts of things we tend to see in our step down beds. The idea is that they stay with us for 16 weeks, and then alternative, onward accommodation is found. We find that bit really difficult. Once we get them in, we do struggle to find that onward accommodation. But we're working on some new models of trying to do that. Whether they'll work or not, I don't know. But that's an amazing facility that we have. They have a companionship worker that works with patients that are in step down, who's non-clinical, and then they have our nursing team manage all of that. I am the clinical lead for that as an advanced nurse practitioner, and then we have some nurses that support that as well. So that's a really great project. What else is on my other slides? I've done all of those ones. What's on the next slide? Common ambition we've already talked about. You've heard all about that. Health engagement work, you've already heard all about that. And the Frontline network. I think that was on this slide because these slides were also used in a presentation that we did around how the services in Brighton are linked in with the NICE guidelines that Theo mentioned earlier. And so you can see we've mapped how they are all linking in with the guidelines. And so Frontline network is part of that as well. So yeah, I don't know if I've gone over. I was trying to be very quick, but hopefully that's a whistle-stop tour of the services we have here in Brighton, and how we're all trying to work together.
No, that was absolutely fantastic, Hannah. Thanks for getting through all of that. And as you said, it's taken a long time to develop all of these services. But also Brighton is one of the areas that we constantly highlight as good practice, collaborative working, developing different types of services when we're talking to other ICSs. So really good to hear about it. I'm going to come to some of the questions in the Q&A now. The first one is around, as Sara mentioned already, people who are leaving care. The comment from Rosie is that given that care experienced people are vastly overrepresented in the homeless population, do you have any thoughts on interventions or targeted supports for these people. So I'm going to make that open to the group. And then there is one specifically for you, Sara. Just wondering if you could talk us through the length of time you would normally work with service users and how you prepare them to prioritize their health independently once they finish working with you. That's from Kelly. So I'm going to come to everyone about supporting people making a transition from care settings. And then Sara, I'll come to you about that question. How do you prioritize people to live independently after you stop engaging with them?
Take care. Yeah, I can talk about care leavers. It's a bit like what I said earlier about people that were previously supported by specialist services end up accessing homeless services, and really it doesn't meet the need because homeless services are so broad. I think in terms of that particular group, often there is some eligibility that they have that others don't in terms of housing if they're still under services or they're younger. Lots of the time, I think with care leavers, the specialist support is around teaching independence. If someone has grown up within the care system, it's likely that they'll have less of an opportunity to be taught things around, say, health, which would be the kind of work we would do. And so supporting people to learn in the same way we would kind of teach anybody, but thinking about people with the ability to learn, but having never been taught things around their health, around their housing and independent living skills. Because a lot of the time we work with people who have lived in care, it's not really about the multiple and complex needs in the sort of same way as people who've rough slept for a long time. It's more kind of around just not being given the opportunity to have lived independently before. And that's a systematic issue. That's not the person's needs necessarily. And so kind of thinking more about how could that person live independently? What would it take? What have they not had the opportunity to learn yet? And kind of put those things in place where possible. We don't do anything particular around care leavers. We don't have a different piece of work for them, but every person that you work with, obviously you work around in a person-centered way around what their needs are. But I think for care leavers, it's more around having the opportunity to learn independence, I think.
Thank you. And Jules or Hannah, do you want to come in on the point about care leavers at all?
I think one of the challenges I think one of the challenges that I've found around care leavers is them bobbing around between local authority areas. And so, sometimes when they leave care, they are given housing in the neighbouring borough rather than where they had grown up. And that can be difficult in terms of, tracking back. So, for example, had a young type 1 diabetic who was placed in the Brighton area when she left care, but all of her childhood paediatric diabetic care had been in a different borough, and it was, there was difficulties and challenges around, trying to access those records and trying to piece together the journey that she'd been on. So I think those are some of the challenges as well. And I think it's just agreeing with Sara as well, is that feeling that these young people are often sort of quite exposed into the world, and they haven't had that guidance or those opportunities, and they're at a young age navigating very complicated systems of housing and health, and it's overwhelming and difficult, and they often get overwhelmed, and there is, I'm not sure whether the statistics would support this, but high incidences of autism and ASD amongst care leavers as well, which is another challenge when trying to navigate systems of health and things. So I think there's huge challenges for that group.
Thank you, Hannah. Jules, did you want to add anything on that point?
No, Great. Not much on care leavers. No.
I think just to say, Hannah, that the point around autism and ASD is a really interesting one, and there is actually some growing evidence coming out at the moment about the prevalence of these conditions amongst care leavers, amongst homeless populations as well. And it's very understandable how, if you have a condition that makes it harder for you to anyway fit in with how society is structured, you're going to end up in these sorts of challenging situations as well. So I think that's a kind of growing piece of evidence that we're getting to at the moment. And then the other question from the chat was for Sarah. So this is about the length of time you normally work with people, and then how you prepare them to be independent once you kind of stop working with them as well.
Sure. So the way the model works in theory is that we work with people whilst they're living in emergency accommodation. We help them with the move on. When they move on to appropriate accommodation, we do some resettlement, and then we leave them to it. And the time that whole thing takes, within that time, we would look at addressing and doing all this work around health, because it takes a long time for people to move on from emergency accommodation. But because every person's experience of that timeline is different, it can change how long we work with people. And some people we work with are chronically ill, and some people are ill temporarily. And so that changes. I would say, on average, we work with somebody for about a year, but we have had people on our caseload for years, and some people move on quickly. So it really depends on someone's level of need. We are always working with the housing stuff, and the timeline of that can just be that it takes a long time. But we have lots of very good success with that around accessing council properties, for example, because lots of people that we work with are eligible for them because their health is poor. But this independent stuff, we're always trying to work towards independence, and ideally we would advocate for people to live as independently as possible. If somebody needs high support accommodation, totally fair enough, we'll use that route, but often that's an automatic thing rather than an individual thing. So when we are working with people, we look at what level of independent accommodation could somebody manage, and then can we advocate for it? Can we see if that's a possibility for them? Alongside that, we're doing all this learning about health. So it kind of depends how well somebody can learn. If somebody is able to, people learn really quickly. It's just they haven't thought to before. So from going to the appointments, from hearing from clinicians, from the experience in their body, something hurt and now it doesn't, things like that are quite like somebody's experience of feeling better. You had a horrible cough, it's now gone. Any of those things, people can learn. I was unwell, there was something happened, and now I'm better. In its kind of simplest form. The more and more times you can do that with someone, the more people kind of want it and like have more kind of engagement with it. And the way I'm describing it is kind of for the more complex people. For some people, that's really straightforward, but it's this experience that somebody has of, if I do that thing, I'll feel better, and trying to keep doing that and kind of keep coming back. What we always say in the medical teaching is around always inviting people back, always keeping people feeling like they want to keep going back to health services. And that I'll keep going back with you up until the point that people feel able to do that without you. Some people don't want to do it without you. And so we will try a bit of trial and error of, I'll make the phone call, book the appointment, you go to this one, and I'll come to the next. And give somebody a go at going on their own and see how they get on. If it really doesn't work, then you go and you try again next time. Or you go with someone to pick up their meds, but they talk to the chemist. These sorts of little bits of learning along the way. And lots of that is just around people have experienced a lot of fear and shame around their health, and actually giving people the confidence to say, you can do it, you can talk to the chemist, you can bring the GP. You understand this stuff, can give people the independence to do it. But it's lots of little things. It's doing it over and over again. I'll call this time, you call next time. This sort of stuff. And that's what kind of starts the independence. When we're looking at discharge, ideally we're thinking the things are in place. Either the support services that aren't us are in place, the things like high support accommodation, or the person is living more independently and has an understanding of how to access those things. Generally, once people are discharged, if they want to ask us a question, they can phone, or we'll help them register at a new GP that isn't the homeless service, so they can start getting used to mainstream, potentially. But I think there's no sort of one size fits all, but there's sort of lots of little bits of learning along the way.
Yeah, and that's really what I was taking from what you were just saying, was that there's this real need for this kind of person-centered approach, adapting to different individuals' needs, and also being very persistent as well, which I think are probably two very key things. So that brings us to the end of our time for the webinar. So just want to say firstly, thank you to the panelists. Thanks for coming, telling us about what you guys are up to and for sharing your thoughts and perspectives as well. Thank you to everyone who's come along and attended today's webinar. If you have any further questions for anyone or anything we've touched on today, you'll be able to get our emails via the Frontline network. So please feel free to get in touch, drop us a line. Wishing you all a good day and hope you enjoy the rest of the conference as well. Thank you everyone for coming along today. Goodbye.
Thank you, Theo. Bye.